Hello and welcome back to my YouTube channel. In this video, after a long time, we will be discussing about the reporting of an organ specimen far commonly encountered by pathologists during routine practice. So, we are going to discuss about the CAP protocol of breast carcinoma because it makes it very easy to report the findings of a breast carcinoma specimen from grossing to microscopy using the CAP protocol. But it is very important to understand what the CAP protocol wants you to report. So, we will be discussing the grade, the tumor size, the margins, the nodes, and the RCB. What is RCB? RCB is nothing but residual cancer burden. That is, after chemotherapy, if the surgeon suspects that there is still some residual carcinoma, what would be the residual carcinoma burden? So, and as always, comments, healthy discussions are always welcome in the comment section below because knowledge shared is wisdom gained. So, let's go. So, before understanding how to report the breast carcinoma specimen findings using the CAP protocol, we have to answer four important questions. First of all, what is the type of tumor that is being seen in the breast carcinoma specimen? Secondly, what is the size of the tumor? Thirdly, what is the extent of the spread of the tumor? That is, which quadrant has it extended to, and does it involve the nodes also, etc. And we should also know the treatment information. Now, we must understand something. In any specimen, in any organ specimen, radiology findings are of utmost importance because the pathologist can correlate and confirm if the findings are appropriate and if there are any additional findings only if they have radiology findings also to substantiate it. Before reporting what are the histopathological features on the microscope, we must first document what are the findings that we know of and that we see on the particular breast carcinoma specimen while grossing the specimen itself. So, first of all, we must document what is the type of excision which is done by the surgeon, whether it is a modified radical mastectomy, whether it is a breast conservation surgery, or whether it is a breast biopsy that if we have received. We must also document what is the tumor size. So, the radiologist would have documented a particular tumor size. We must, as a pathologist, first of all confirm if this is the same measurement that we are looking on, or we should document if the tumor size is more or less than what is given on the radiology report. We must also document the tumor margin. Now, mostly the surgeon would usually tag the margins of the particular tumor on the specimen, or he would paint it, and it is up to us to determine by giving cut sections to the particular specimen whether the particular tumor is close to, whether it is involving the margin or whether it is far away from the margin. And then we must also assess the lymph node involvement of the particular breast carcinoma specimen. So that we can do it grossly if when the surgeon has sent the axillary lymph nodes along with the breast carcinoma specimen. Now, all these points will be elaborated in the further sections. Now, let us try to understand what is the type of excision in a breast carcinoma specimen according to the CAP protocol. Okay, so if only a lump is removed, that is a part of a breast is removed, then we call it lumpectomy, partial mastectomy, or quadrectomy. Okay, so part of breast is lumpectomy, quadratectomy, partial mastectomy. Now, if the entire breast is removed, then it is total mastectomy. Entire breast is total mastectomy. So, In a simple mastectomy, there is no axillary lymph node dissection. In modified radical mastectomy, there is axillary lymph node dissection. In a skin sparing mastectomy, the nipple is usually removed but the skin is preserved. So skin is preserved but not the nipple. That is usually removed. And in a nipple sparing mastectomy, both the skin and nipple are preserved. So these are the different kind of excisions that the surgeons usually do. Okay, and please remember that this invasive breast resection protocol by CAP is not meant for core biopsies or small incisional biopsy or re-excision specimens. Now we will move on to the tumor size. Why is the tumor size important? The tumor size is important because it contributes to the T staging. Okay, that is according to the PTNM staging. This T is tumor size. Okay, so only the invasive component is taken into consideration, not the surrounding DCS. What do I mean by this statement? Please see the diagram here. So I will give you 6 situations wherein the tumor size matters. So this is what I mean by this. So this tumor size is taken into account, not the surrounding DCIS. In this case, if you see, there is a core needle biopsy that has been excised, then following that, depending on the diagnosis, excision is also done. Just because they have extracted a core needle biopsy and the excision, do not add both of them. So don't add the size of the core biopsy and the tumor resection. The excision size is the size that has to be considered as a tumor size. Now, suppose if you see that the biopsy site has changed. Say for example, on the surgeon has written that the right breast is affected, but on the histology specimen, that is on the gross specimen, you find that the left breast is affected. Whether the site of the tumor can change or even the quadrant of tumor can change. The surgeon may have mentioned that the right upper outer quadrant is affected, but on the gross specimen you find that the right inner quadrant is affected. So in such a case, you have to refer to the radiology or you'll have to call and consult with the surgeon. Now, in case there are many carcinomas, like for example, you have an tumor here, and then on the same quadrant you have 2 separate tumors on a little different area than where the current tumor is placed. In this case, the largest size is taken into consideration. The largest size is taken into consideration in case there are many carcinomatous nodules or tumors. Now, whenever you see any adjacent carcinoma, like for example on radiology, it is written that there is a nodule which is 5 into 5 centimeters, but on gross you see that there are 2 nodules adjacent to each other. Here you will have to be very careful when you're reporting, and here also you will have to rely on the radiology, or you will have to consult with the surgeon as to what should be done. And suppose if there are 2, while giving cut section to the specimen on 2 different fragments, you have carcinoma, do not add the size in each tissue fragment. You have to take it as one whole for a tumor section. Like for example, you're giving cut sections, and then on one tissue fragment you find it is say 3 into 3 into 2. On this you find it is 2 into 1 into 0.5. You cannot report it as 2 different tissue carcinomas. You have to include this as one entire tumor size. Okay. Next we go to the margin. So what do you mean by margin? Let me elaborate again. Say for example, we'll take the example of a rotten mango. Now in this rotten mango, if you extrapolate or it to the breast carcinoma specimen, this ripened area is the normal tissue. This rotten part is the cancer, and this section between the rotten part and the skin, this is the margin. Okay, so why is this margin very important? Margin is very important because it affects the decision of re-excision. Depending on whether the margin is positive or negative, the surgeon will take a call if he has to re-excise more areas, or it could be cured with chemotherapy or radiotherapy, or if the margin is negative, that means his excision is complete. So what do you mean by a positive margin? Now this is something that many practicing pathologists get very confused. Positive margin means ink has to be present on the cancer cells. It cannot, even if it is if the margin is 0.1 centimeter away from the tumor, that margin is negative. The ink has to be present on the cancer cells for it to be called as a positive margin. Like I have explained in this diagram, say for example, this is a breast specimen, the carcinoma is here, this is the further tissue, and this is the area that you have inked as your margin. Okay, so even if it is 0.1 centimeter, this margin is negative for the carcinoma because distance from the carcinoma is 0.1 centimeter. Okay, so in a breast carcinoma specimen, what are the margins that we take, especially if it is a MRM or a breast conservation surgery? In any of these cases, we take the superior margin, the inferior margin, medial, lateral, anterior and posterior. Okay, so what is the anterior margin? The skin is always the anterior margin. Okay, and this is the tissue with carcinoma, and the base margin is nothing but the muscle fascia or the chest wall margin. Okay, so if carcinoma is present in this base margin, then post mastectomy radiation is the treatment that is usually done. Okay, now that we understood what you should report as margin positive, say if the margin is positive, it is also important to understand whether it is a unifocal margin, okay, whether it is multifocal or whether it is extensive. Now let us move on to the next section in the CAP protocol of breast carcinoma specimen reporting, which is the lymph nodes. So the breast cancer can always spread through the lymph nodes. So examining them helps determine the end stage of the cancer and whether any additional treatment needs to be there. What are the types of lymph nodes that we see? The first is the sentinel lymph nodes. So sentinel lymph nodes are the first lymph nodes that drain the breast. So these are also called as gatekeeper lymph nodes. So during surgery, the surgeon always injects a blue dye, and the first node that takes up this blue dye is called as the sentinel lymph node. The next are the axillary lymph nodes. So axillary lymph nodes are the lymph nodes which are there in the armpit. Now these are usually divided into 3 levels. So level 1 is closest to the breast specimen, and they are located on the outer side of the pectoralis minor. The second is including the Rotter's nodes, and these are located behind the pectoralis major. So first is behind pectoralis minor, and the third level is also called as apical lymph nodes, and they are only removed if suspicious. The next is a intramammary lymph node, and these lymph node drain within the breast tissue. The next is the internal mammary or the supraclavicular or the infraclavicular lymph nodes, and these are less commonly removed. So, when it comes to lymph nodes, it is very important to understand the concept of ITC, which is isolated tumor cells, macrometastasis, and micrometastasis. This is especially important in case of grossly negative lymph nodes. Now, how do you differentiate between these three terminology? Let us take the example of visitors visiting a particular house. Now, for example, you have just two people visiting a particular house, that is equivalent to ITC or isolated tumor cells. So isolated tumor cells are nothing but a small group, that is fewer than 200 cells in one section. Okay, so what do I mean by 200 cells? That means 200 cancer cells in one section. So in this case, we give the staging as PNO and I plus. Okay, in this there will be no metastatic deposit. The next is macrometastasis. So macrometastasis is extrapolated to, say, a family of 4 is visiting a particular house. So in this case, you grade it as PN1MI plus. Okay, and in this you give metastatic deposit as positive. Okay, so this is more than 0.2 mm but less than 2 mm of cancer cells. Okay, micrometastasis is given as METS deposit positive. Here you extrapolate it to a large group of people coming and visiting a particular house. Okay, so here it is more than 2 mm, and here it depends on the number of nodes that are usually involved. Okay, so you grade it as N1, N2, etc. Say one node is involved, then it's N1, 2 nodes are involved, then it is N2. We'll now move on to the microscopy findings that we need to report on a CAP protocol. Okay, so as we all know, the breast carcinoma is always graded as per the Nottingham histological grade, wherein they are the SBR grading, wherein it is graded on 3 different criteria. The first is tubule formation, where 1 is majority are in tubules, 2 is moderate degree 10 to 75%, majority is more than 75%, and 3 is little to none, less than 10% tubules, mostly seen in solid sheets. The next is nuclear pleomorphism. So small, regular and uniform pleomorphism, almost looking like a normal cell, is graded as 1. When it is moderate increase in size and slight variability as compared to the normal cell, it is given grade 2. And when there is marked variation as compared to the normal cell, it is given as grade 3. Mitotic activity, grade 1 is 0 to 8 mitosis per 10 High per field. Grade 2 is 9 to 17 mitosis per 10 High per field, and grade 3 is more than 18 mitosis per 10 High per field. Based on these grades, a combined histological score is given. So scores 3 to 5 is well differentiated, which is grade 1, 6 to 7 is moderately differentiated, which is grade 2, and 8 to 9 is poorly differentiated, which is grade 3. Now, when you report the microscopy, you have to understand few concepts. The first is extensive intraductal component. So always we have to check if DCIS is present. Now DCIS significance is not there much in when it comes to MRM or mastectomy specimens. So in a breast conserving surgery, if you see DCIS, then the prognosis is very, very bad. Okay, what does this mean? That means the EIC or extensive intraductal component tumors, they have possible DCIS if the margins are close. So what do you mean if margins are close and if DCIS is present, there is increased chance of local recurrence of the particular tumor. So in order to understand this concept better, I will explain it through diagrams given in the CAP protocol. Now in this case, you can see that there is DCIS foci inside as well as outside. So extensive intraductal component is present. So here you can see in B, 90% of DCIS, as you can see here, it has and there is less than 10 mm of invasive foci. Here also extensive intraductal component is positive. Now in this case, there is invasive tumor and very little DCIS or no DCIS. So in this case, EIC is negative, and here this is an invasive tumor and outside, only outside there is DCIS. So in this case also EIC is negative. A very important concept that we have to understand while reporting the breast carcinoma specimen via CAP protocol is the residual cancer burden. Okay, so how do you understand this topic or this concept? So say let me take an analogy of a pizza. Okay, so in this pizza, here you have the base over here and you have the toppings. Okay, so this can be extrapolated to the breast carcinoma specimen with cancer containing tumor cells. Okay, now chemotherapy is done. Okay, now after CT, someone has eaten all the toppings and there is only the pizza base. This pizza base is nothing but the tumor bed. Okay, now how do you measure the residual cancer burden? Okay, so originally this was the tumor dimension. Okay, currently there are only scattered cells, so this is only what we have to measure, okay, for determining the residual cancer burden. Now in this particular foci, how do you estimate the cancer cellularity? Say for example, 90% of that tumor bed has only scar and fibrosis and 10% is cancer cell. So cancer cellularity is only 10%. Okay, and how to estimate the DCI cellularity? Amongst the 10% cancer cells from the previous examination, 8% is carcinoma and 2% is DCIS, then 2% is only DCIS cellularity. Okay, so lymph nodes in this case have to be included, okay, into the reporting. Now how do you estimate the response? Say for example, let us take two patients. Okay, patient A has a tumor bed of 4 cm and cancer cellularity of 2%. Lymph nodes are also negative. So this will be graded as RCB1, which is excellent response. Okay, patient B has a tumor bed of 5 cm and cancer cells of 80% and the lymph nodes are also positive. Okay, in this case, RCB or residual cancer burden is grade 3, which is poor response. So I hope you enjoyed this video. If you did, please like, comment, share and subscribe. And don't forget to tune in to more videos. And as always, comments, healthy discussions are always welcome in the comment section below. Thank you for watching. See you in the next video.